Hello learners. Today let's discuss the role of social determinants on Indian women's health. Social determinants of health refer to non-medical factors that shape health outcomes. These factors impact birth, growth, life, work and age as defined by the WHO in 2010. The existing political, economic and social structures heavily influence these determinants. They impact creating opportunities that generate equal outcomes for different groups. These opportunities include education, employment, income, social support, housing, and access to healthcare. In the Indian context, social stratification based on the intersection of caste, class, gender, and geography acts as a multiplier of inequality, creating a landscape where health outcomes are dictated by one's position in the social hierarchy. Marginalized women do not experience these barriers in isolation. They navigate a triple burden where the material deprivation of poverty is compounded by gendered cultural expectations and the systemic exclusion inherent in caste-based societies. These layered disadvantages manifest in stark physiological and psychological tolls. As noted by Patel et al. 2015, the convergence of these factors result in significantly high rates of maternal mortality, chronic malnutrition, and severe mental health issues among Indian women from marginalized backgrounds. The Dahlgren and Whitehead model of 1991 is a valuable framework for better understanding SDOH. This model presents health determinants in the form of concentric layers. Each layer begins with individual lifestyle factors and ends with broader conditions related to socioeconomic, cultural, and environmental norms. The model emphasizes that health is not just a personal responsibility, but also an outcome of social structures. Recognizing the social determinants of health is an essential prerequisite for developing inclusive and equitable public health strategies. When interventions focus solely on the biological or clinical aspect of disease, they fail to address the root causes that determine who gets sick and who has the resources to recover. Without a structural lens, healthcare remains a reactive system rather than a transformative one. As noted by Sen, Oslin, and George 2007, the efficacy of any medical intervention is strictly limited if the social, economic, and political environment continues to produce inequality. A counter to foundational definition provided by the World Health Organization, health is a holistic concept defined as a state of complete physical, mental, and social well-being rather than merely the absence of disease or infirmity. This definition challenges the traditional medical model by asserting that a person's health is not just the result of clinical interventions, but the outcome of the social and environmental conditions in which they exist. In contrast, healthcare is more specific to the services related to diagnosis, treating, and managing illness or injustice. It includes hospital, clinic, medical professionals, medications, and procedures. While clinical medicine is often the most visible aspect of health sector, it is statistically only a secondary contributor to overall population's well-being. Research indicates that clinical care accounts for only 10 to 20% of the modificable contributors to health outcomes. The remaining 80 to 90% is determined by the social determinants of health, like the condition in which people are born, grow, live, work, and age. As noted by McGuinness, William Russo, and Nickman in 2002, focusing solely on hospital-based interventions is akin to treating the symptoms of a systemic crisis without addressing the environment that produces it. The distinction between curative and preventive care is particularly critical in Indian context, where a significant portion of health policy and funding is historically directed towards curative healthcare. While measures required to address the root cause of ill health, such as systemic poverty, deep-seated gender inequality, and inadequate sanitation. This strategic imbalance limits the long-term effectiveness of the existing healthcare system as it treats the systems of a social crisis rather than the environment that breeds it. For many Indian women, particularly those in rural and marginalized communities, this curative bias results in persistent health disparities. Gender play a fundamental role in shaping healthcare outcomes by influencing how individuals experience health risks and navigate medical services. As a social construct, gender encompasses the roles, behavior, expectations, and power relations that societies assign based on perceived sex differences. Unlike biological sex, gender is a product of social and cultural norms that create unequal access to resources and opportunities, serving as a powerful and pervasive social determinant of social health across the globe. In India, gender inequality manifests as a direct barrier to well-being. Patriarchal norms frequently restrict women's autonomy regarding their health, mobility, and reproductive rights. A critical manifestation of this is the requirement for women to secure permission from male family members before seeking professional medical support. As noted by Barua and Kurz in 2001, the time lost in negotiating these domestic permission leads to dangerous delays in receiving treatment. Gender-based violence is a pervasive manifestation of structural violence that profoundly compromises the physical, mental, and reproductive health of women and girls. According to data from the National Family Health Survey 5, nearly one-third of Indian women have experienced physical or sexual violence in their lifetime. These experiences do not exist in isolation. They create a ripple effect of trauma and injury that extends far beyond the initial incident. The pervasive nature of gender-based violence serves as a significant deterrent to healthcare utilization, as the associated stigma and fear, often reinforced by unsympathetic institutional response, discourage women from seeking the medical help they desperately need. The health impact of GBV are multifaceted, encompassing immediate physical trauma, long-term chronic pain, unintended pregnancies, and debilitating mental health conditions such as PTSD and depression. When a healthcare system lacks a trauma-informed approach, it risks re-traumatizing survivors. As noted by the International Institute for Population Sciences 2021, the intersection of violence and health seeking is a critical point of failure in current public health delivery, where the fear of domestic repercussions or social shaming acts as a barrier as physical as any geographic distance. Multiple intersecting social determinants shape the health of Indian women and create disparities in access, quality, and outcome of healthcare. These determinants include poverty, education, employment, caste, geographic location, and gender-based norms. Understanding these interconnected factors is critical to addressing systemic inequalities in women's health across India. Education and literacy serve as the cognitive infrastructure of public health, acting as foundational social determinants that dictate a woman's ability to exercise health sovereignty. In India, a higher level of education are inextricably linked to the cascade of positive outcomes, including delayed marriages, reduced fertility rates, and the proactive use of maternal healthcare services. As noted by Basu and Stephenson 2005, education functions as a tool of empowerment that enhances health literacy, allowing women to decode complex medical information, navigate bureaucratic hospital system, and make autonomous decisions regarding contraception and nutrition. The empirical evidence from the National Family Health Survey 5 highlights a stark knowledge gap fueled by systemic inequality. Women with no formal education show sustainably lower utilization rates for antenatal care and institutional deliveries compared to their educational peers. Economic status and employment function as the primary engines of health sovereignty, determining the women's ability to command the resource necessary for a dignified and healthy life. In the Indian context, the shift from economic dependence to financial autonomy is often the single most significant predictor of empowered health outcomes. While stable employment in the formal sector is strongly associated with delayed marriage, enhanced reproductive agency, and better utilization of health services, the reality for most Indian women is starkly different. As noted by the International Labour Organization 2018, women are overwhelmingly concentrated in informal employment such as agriculture, domestic work, and small-scale vending. The gender wage gap further hollows out women's health potential. While women earning approximately 20% lesser than men, a disparity that widens significantly among marginalized caste groups and in rural areas. The COVID-19 pandemic served as a catalyst for deeper economic vulnerability, causing a sharp drop in female labor force participation. By 2026, the residual effect of this shock manifested as highlighted rates of anemia, malnutrition, and depression among women who lost their precarious informal livelihoods. Achieving clinical justice in this landscape requires moving beyond simple medical and towards gender-responsive labor policies and robust social protection for informal workers. Investing in women's economic empowerment is not merely an optical goal, it is a fundamental public health intervention that provides the financial immune system required to survive and thrive. In India, the triad of social class, caste, and religion functions as a rigid structural framework that dictates the distribution of health and life expectancy. These hierarchies do more than just influence individual choices. They govern the very gates to education, employment, and social capital. As noted by Subramaniam et al. 2006, these determinants shape the well-being of women across generations, creating a cycle where historical disadvantage is physically manifested as poor health outcomes. The caste system remains one of the most potent drivers of health inequalities in India, forcing women from marginalized communities, especially Dalit, scheduled caste, Adivasis, like scheduled tribes, to navigate a reality of triple jeopardy, where gender, caste, and class intersect to undermine their well-being. This intersectional burden manifests most sharply as clinical discrimination, where Dalit and tribal women are disproportionately likely to encounter dehumanizing practices such as touch avoidance, verbal abuse, or outright neglect within health facilities. Beyond the clinic, resource deprivation plays a foundational role in sustaining these health disparities. The systemic exclusion of these communities from land ownership and stable housing leads to high-density living and underdeveloped areas, which directly correlates with higher rates of chronic malnutrition and anemia. This is not merely an economic failure, but a form of structural violence that limits the physical development and immunity of women from birth. According to Thakur et al. 2021, this culminates in profound systemic neglect where marginalized women are significantly less likely to receive full antenatal care or institutional delivery support. This lack of utilization is not a matter of personal choice or cultural resistance, but a rational response to medical system that historically and structurally treats their bodies as peripheral to the national health agenda. Cultural and gender norms function as an invisible but powerful regulatory framework that dictates the permissibility of healthcare for Indian women. These norms are not merely social customs, they are structural determinants that reinforce traditional gender roles, positioning women primarily as caregivers whose health is secondary to the needs of household. As noted by Sen and Oslin 2008, this distribution of roles limits a woman's autonomy, mobility, and decision-making power, creating a permission-based medical existence. In many communities, a woman's ability to visit a doctor is contingent on the approval of male family member, a delay that often turns treatable conditions, particularly in the realm of reproductive and mental health, into a chronic or life-threatening crisis. Furthermore, deep-seated cultural preferences such as son preference codify systemic discrimination from before birth. This bias manifests in lethal practices like female feticide and the systemic undernutrition of girl children who are often fed last and least within the family unit. These practices do more than skew sex ratio. They create a lifetime of physiological vulnerability, leading to higher maternal mortality and stunted physical development. In the Indian context, caste and gender do not function as parallel tracks of disadvantage. Instead, they intersect to produce a unique and compounded form of discrimination that fundamentally dictates the health outcomes of women from marginalized communities. This intersectionality places Dalit and Adivasi women at the crosshair of two pervasive systems of oppression: caste-based social exclusion and patriarchal gender norms. As noted by Krishnan in 2016, this double burden creates a reality where these women are marginalized not only within the broader national landscape, but often within their own communities and the very institution designed to provide care. The deeply entrenched caste hierarchy determines a woman's access to the foundational pillars of health, education, employment, and political participation. When this is coupled with gender discrimination, the result is a profound restriction of autonomy and a highlighted vulnerability to structural violence. For example, Desai and Dubey 2012 highlight that Dalit women frequently report experiences of abuse and neglect from healthcare providers, ranging from touch avoidance to verbal dehumanization. These clinical encounters reinforce a trust deficit, leading to delayed or denied medical care, and transforms manageable health issues into life-threatening crises. Geographical location, particularly the rural-urban divide, serve as a physical manifestation of health inequality, dictating the quality and speed of medical intervention available to Indian women. In rural landscape, the barriers to care are often infrastructural. A scarcity of trained professionals, prohibitive transportation costs, and a lack of specialized facility create a distance decay, effect that health outcomes worsen the further a woman's life from a district center. As noted by Patel et al. 2015, the modesty and privacy often prevent women from seeking care from male doctors. Data from the National Family Health Survey 5 confirms that rural women are systematically less likely to receive complete antenatal care or postnatal checkups compared to their urban counterparts. These disparities are not merely geographical but are reinforced by low literacy rates and traditional gender norms that restrict a woman's mobility. Conversely, urban centers present a paradox of access without quality for the marginalized. While resource-rich, the urban landscape is deeply stratified. Women living in informal settlements or slums face overcrowding, environmental hazards, and a lack of basic sanitation. According to Subramaniam et al. 2013, the absence of private toilets and clean water in these high-density areas contributes to poor menstrual hygiene, a higher prevalence of infectious diseases, and significant mental health stressors. Rural poverty in India has been a notable decline in recent years, with extreme poverty rates dropping from 18.4% in 2011-12 to 2.8% in 2022-23. However, these statistics often mask the lived realities of rural Indian women whose experiences of poverty and access to care are shaped by deep-rooted gender disparities, persistent time poverty, and limited visibility in official data. Rural Indian women typically spend more than 5 hours daily on unpaid tasks such as cooking, cleaning, caring for children, tending to livestock, and sometimes managing small farms. Despite their significant contribution to household and agriculture productivity, much of this labor remains unrecognized in economic matrix and employment data. According to National Statistical Office's 2024 Time Use Survey, women dictate 81.5% of their time to unpaid domestic work, while men spend only 27%. This time poverty leaves women with limited opportunity for paid employment or self-care, perpetuating cycles of economic and social disadvantage. While recent years have seen a rise in rural female employment, particularly in agriculture and self-employment, gender gap remains stark. Only about 1 in 4 women is counted as part of labor force, and there are still 234 million more men than women in paid employment. Many women's economic activities are informed or home-based. While recent years have seen a rise in rural female employment, particularly in agriculture and self-employment, gender gaps remain stark. Only about 1 in 4 women is counted as part of labor force, and there are still 234 million more men than women in paid employment. Many women's economic activities are informal or home-based, offering little scrutiny or access to social protection. Employment growth has outpaced population growth since 2021-22, and self-employment among rural women is rising. Yet, most of this work is low-paid and lacks benefit. Societal expectations and gender norms further limit rural women's autonomy. Women pursuing work outside the home often face questions about childcare and family responsibilities, reinforcing that their primary role is within the household. This visibility gap means that even as women contribute sustainably to the families and communities, their needs and rights are frequently overlooked in policy and service delivery. Migration, both internal and international, significantly shape women's health and well-being, often exposing them to new vulnerabilities while also offering opportunities for improved access to services. In India, the increasing trend of female migration, particularly from rural to urban areas, has profound implications for women's physical, mental, and reproductive health. Women migrants often face critical health issues related to pregnancy and maternal care, including a higher prevalence of anemia, increased risk of sexually transmitted infections, and inadequate access to antenatal and delivery services. Studies show that a large proportion of migrant women do not receive the recommended number of antenatal checkups, and many deliver at home without skilled attendants, raising risk for both mothers and infants. For example, among construction workers in Punjab, only 10.5% of migrant women received 3 or more antenatal checkups, and nearly 3/4 did not receive even a single dose of tetanus, as explored by a survey. Migration exposes women to heightened emotional, physical, and mental strain. The stress of displacement, adaptation to new environment, and reintegration into former communities can lead to psychological distress. Migrant women often face poor living conditions and working conditions, job insecurity, exploitation, which contribute to anxiety, depression, and increased vulnerability to domestic violence and substance abuse. The migration status of mothers directly affect child health outcomes in urban areas. Children of migrant women are more likely to suffer from undernutrition, anemia, and lower rates of vaccination. The duration and pattern of migration further influence these outcomes, with recently migrated families experiencing greater health disadvantages. The stream and duration of migrant play a crucial role in women's health knowledge, particularly regarding HIV or AIDS. Women migrating to urban areas generally have better health status and awareness of AIDS compared to those migrating to rural areas, but significant gaps remain. Strengthening information, education, and communication program is essential to improve health literacy among migrant women. Social determinants of health, including income, education, gender, caste, family support, and living conditions, play a decisive role in shaping health outcomes in India. Their influence is evident across various health domains, from maternal and child health to non-communicable disease and mental health. Maternal and child health outcomes are deeply affected by social factors. Lack of spousal or familial support, lower educational levels, time constraints, and unstable housing significantly limit rural women's participation in health interventions, access to care. For example, women with less education, younger women, and those living in joint families are less likely to receive adequate maternal care. While policy efforts have reduced infant mortality and improved access, persistent inequalities remain between socioeconomic, rural, urban, and caste groups. Despite improvements in food security through policies like the National Food Security Act, undernutrition and anemia remain significant challenges, especially among women and children in marginalized communities. Poverty, low maternal education, and lack of social protection are key determinants that perpetuate poor nutrition outcomes. These issues are compounded by gender and caste-based disparities, which limit access to nutritious food and healthcare services. Non-communicable diseases such as diabetes and cardiovascular diseases are increasingly prevalent among low socioeconomic groups in India. Socioeconomic status, education, and occupation are strongly linked to the risks, awareness, and management of these conditions. Lower education and income levels are associated with a higher prevalence of risk factors. Example, tobacco use, obesity, hypertension, poorer disease outcomes, etc. Urban poor and marginalized communities face greater barriers to preventive care and treatment, resulting in higher morbidity and mortality. Social determinants such as poverty, lack of social support, gender discrimination, and unstable living conditions contribute to poor mental health outcomes. Women in rural areas, for example, experience significant emotional and mental strain due to time poverty, limited autonomy, and lack of supportive networks. These factors increase vulnerability to anxiety, depression, and other mental health issues. In summary, social determinants such as education, income, gender, caste, and family support are central to health outcomes in India, influencing everything from maternal to child health to chronic disease and mental well-being. Addressing these determinants through targeted policies and community interventions is crucial for achieving health equity and improving overall population health. Measuring social determinants of health involves using standardized tools and indicators that captures the broad conditions influencing health such as education, employment, housing, social protection, and access to healthcare. Screening tools for health-related social conditions are increasingly integrated into healthcare and research settings. Commonly used tools access domains like housing stability, food security, employment status, social support, and access to services, aligning with recommendations from organizations such as the Institute of Medicine. These tools help quantify needs, identify patterns of vulnerability, and guide targeted interventions. The National Family Health Survey 5 provides comprehensive data on population health, nutrition, reproductive health, and social indicators across states and districts. The district-level household survey focuses on reproductive and child health, health infrastructure, and service utilization at the district level. While the Census of India offers demographic, social, and economic data, including information on education, housing, and employment, which are vital for SDH research. These sources enable policymakers and researchers to track progress, identify disparities, and design context-specific interventions. Despite progress, several challenges hinder effective measurement and research on SDH in India. Some of the challenges include standardization. There is considerable variation in definitions, indicators, and methods for capturing SDH, making comparison and integration into health systems difficult. Next, data gaps. Many social determinants such as social stability or nuanced aspect of gender and caste are not routinely or adequately captured in national surveys. SDH research requires coordination across multiple sectors and stakeholders, complicating data collection and analysis. Fourth, equity and representation. Marginalized groups, rural populations, and women may be underrepresented or misrepresented in data, leading to persistent inequality. And last, resource constraints. So collecting high quality disaggregated data is resource incentive and may be limited by funding, infrastructure, and trained personnel. So while India has made strides in developing policies and increased financial allocations to address SDH, persistent inequality highlight the need for improved measurement tools, standardized indicators, and inclusive data collection strategies. The strategies and interventions involved in addressing social determinants include, first, empowerment and education. So empowering women and improving access to education are fundamental strategies for addressing social determinants of health in India. Education enhances health literacy and decision making and increases women's participation in health interventions and the workforce. The Right to Education Act has made education free and compulsory for children, improving health outcomes and narrowing gaps between socioeconomic groups as mentioned by Kaur et al. 2025. Targeted programs should focus on women with lower education layers, younger women and those in joint families, as these groups are more likely to face barriers due to the lack of support and awareness. Next is economic upliftment initiatives. So poverty alleviation and economic empowerment are critical for improving health outcomes. Policies such as the National Food Security Act, which provides subsidized food grains to 2/3 of India's population, have improved living conditions and nutrition. Economic upliftment initiatives, including employment schemes and social protection programs, help reduce vulnerability and enable families to afford healthcare, nutritional food, and stable housing, which are the key determinants of health. However, persistent inequalities remain, highlighting the need for more inclusive and targeted economic policies. Community mobilization. Community engagement and mobilization effectively address social determinants at the grassroots level. Civil participation has increased, especially among marginalized populations, leading to better awareness of health rights and entitlements. Trained community healthcare workers, such as accredited social health activities, popularly known as ASHAs, are crucial in connecting women to services and supporting participation in health programs. Community-based interventions can address barriers like lack of spousal and familial support, time constraint, and unstable housing, which are significant for rural women. Integrative healthcare approaches. Integrative approaches that combine medical care with social support are essential for tracking the complex web of social determinants. Health and wellness centers under the National Health Mission provide comprehensive primary care close to communities, including preventive, promotional, and rehabilitative services. Collaboration across sectors, health, education, and nutrition and social protection is necessary to ensuring interventions reach the most disadvantaged groups. Addressing social determinants of health in India requires a multi-pronged approach, empowering women from education, supporting economic upliftment, mobilizing communities, and integrating healthcare with social support systems. While significant progress has been made, continued focus on equity, policy coherence, and local adaptation is essential for sustainable improvements in health outcomes. Thank you.